So skip this page because we're going to talk about that next. Let's see. Okay. All right. So if you look here, I kind of, if you're somebody that likes to study, if you're visual, I've put these in kind of a linear pattern. So we talk about acute coronary syndrome, but if you look at these two sections here, this is acute coronary syndrome, and we have them separated by unstable angina and an MI. Okay. And then we have this MI, and it's broken into a non-ST elevated MI and an ST elevated MI. And you say, well, how do you know if they have unstable angina versus non-ST elevated MI? Well, you've got to look at your two identifying factors. So you have to look at your EKG and your biomarkers. So let's start with ST elevated MI. I always say this is the worst of the worst, ST elevated MI. So how do I know that my patient's having an ST elevated MI? Well, they're going to have positive ST changes. Okay, we're going to see that ST elevation usually, and they're going to have positive biomarkers. That's your CK troponin, right? Or CKMB. Then you have your non-ST elevated MI. Well, for it to be an MI, you have to be either have a positive ST elevation or positive biomarkers or both. So in this case, since it's a non-ST elevated MI, of course there's no ST change because it's non-ST elevated. So they have to have positive biomarkers for this to be an MI. So that's how I remember that in my mind. ST elevated MI, they got both. Non-ST elevated MI, it's a negative ST elevation, but positive biomarkers. And then unstable angina is just going to be the opposite, okay? Because it's not going to be both, because ST elevated MI is both. It's not going to be the non-ST elevated MI, because that has the positive biomarkers and no ST elevation. So the unstable angina has the ST elevation, but the biomarkers are negative, okay? The other thing that helps me remember, so the biomarkers are released when the heart is struggling, right? When the heart is struggling, those biomarkers are released into the bloodstream, and we're able to pick them up diagnostically in the lab work. So the other thing I think about is unstable angina. Remember, there's not a complete blockage. In an MI, you've got a blockage. Unstable angina, there's not a complete blockage. So you're not going to necessarily see the release of those biomarkers because there is still some blood flow that's getting to that coronary tissue. Okay, so that's the other thing that helps me remember that. So how do we separate these in our mind? Well, your vessel's not completely occluded in the unstable angina, but in an MI, the vessel's completely included. This is why it's still an emergency, because if we do not fix it, it will become a full-blown MI. So it is just as much of an emergency as if the vessel's completely occluded itself. We just have a little bit more time sometimes, okay? So, of course, every single nurse needs to know the clinical manifestations if they come in. So, what do you see with unstable angina? Typical chest pressure radiating to the left arm, usually brought on by stress or exercise, lasts 2 to 5 minutes, very easily relieved by rest and nitro, and there's not many associated symptoms. So think about this. If the vessel's not completely occluded, but it's partially occluded, okay, and now, if you guys can see this, and now, it's not, now the patient starts to engage activity, and now the blood has to flow harder and faster. So now when they engage activity, we see that this blood vessel is kind of occluded, which actually causes them to have pain. Because when they need more blood to flow through, it can't. The blood can't get through as much as it likes to because of this blockage. So they have the chest pain. We give nitro, which dilates this vessel open, allows the blood to flow through a little bit better, and it relieves the pain. Or if the patient sits down and rests, because it's not completely occluded, now we don't have that high pressure in the vessel, that they sit down, the pain goes away because now the heart's able to rest and it's not having pain because the blood's able to flow through okay. If you have a full-blown MI, they're still going to have chest pain radiating to left arm. The symptoms are worse. So now it's radiating to the jaw, it's radiating to the back. Sometimes, we talk about unstable angina comes on by stress or exercise. In an MI, once that vessel's completely occluded, it can happen at any time. So sometimes it comes on without warning, sometimes early in the morning or even at rest. The unstable angina lasts 2 to 5 minutes because when they rest or we give the nitro, the pain goes away. unstable or the full-blown MI lasts more than 20 minutes, right? The vessel's completely occluded. So now there's nothing that we're doing that's really necessarily getting rid of the pain. We're not getting that blood to flow through that vessel. So the heart is painful. We're having this pain in this coronary tissue that's radiating all over because now it's hypoxic. Now that tissue is not getting perfused the way it should. So one of the clinical manifestations is they're going to have the significant pain and shortness of breath. The nitro, if your vessel's completely occluded and I dilated open, guess what? It's still occluded. So the nitro doesn't work in these patients, but the opioids does. So it relieves the pain. In unstable angina, no associated symptoms, right? So we have milder symptoms. And in the MI, we actually have associated symptoms. So these patients become sick. Nausea, vomiting, sweating, shortness of breath, chest pain, fatigue, maybe throat discomfort or dizziness, difficulty swallowing, arm weakness, and this feeling of impending doom, Okay. And then the third type is we have this variant. Okay. And these patients will have the pain at rest and it's spasms. Okay. They do have a positive ST elevation and it's cyclic. So it happens kind of the same time of the day. Okay. So they could be sitting at rest. The vessel will start to spasm. Okay. So the vessel spasm, now they start to have chest pain. And it happens the same time of the day. Once the vessel stops spasming and relaxes, the pain goes away. So this is called Prinzmental or variant angina because it's variable. It comes and it goes. It comes and it goes. But here's really important. Our treatment is nitro. Of course, let's vasodilate so we don't have that spasm anymore. And let's go back to those beautiful calcium channel blockers, right? If we stop calcium from going into the cell, is that vessel going to spasm? No, it's not going to contract like that. So calcium channel blockers and nitro are beautiful interventions for this. Okay. So now I'm going to tell you a story. So my uncle didn't believe in doctors, didn't believe in healthcare, hated doctors. It's like, I'm not going to go. Every time I go, they tell me something bad. I'm like, well, yeah, because you don't go when you're supposed to take care of your problem. So when you have to go, it's always something bad because now you've let this problem sit for a long time. So his neighbor was watching him and he would cut the grass. One strip, come, sit down. Would be shorter breath, chest pain. The pain would go away. Do a second strip of the yard, cutting the grass, sit down. Pain would go away. Third strip, down and back, sit down. So the neighbor's like, what is he doing? Like this, he's been cutting the grass for almost 2 hours now. Calls my aunt and she's like, can you go over and check on your uncle? I don't know what's wrong with him. He's like trying to cut the grass and he keeps sitting down, taking a break. And I said, okay. In my mind, I'm thinking, oh my gosh, he is having a heart attack. He is about to have a full-blown heart attack. And when he's resting, because he has this unstable angina, when he's resting, the pain goes away because it's decreasing the workload of the heart. So when he sits down, the heart doesn't have to pump as hard. The vessels are allowed to let the blood flow a little bit better and his body relaxes. He does the exercise. The heart has to work harder. You need more oxygen. The pain comes on because the heart can't get the oxygen. So I get over there and I said, what are you doing, Uncle Lou? What are you doing? Oh, I just keep getting this weird pain, just going down my arm through to my back. And I said, really? He said, yeah, every time I cut the grass. I said, oh, it's probably your gallbladder. And he's like, really? I said, oh yeah. I said, you're going to have this pain for a long time. I said, why don't we call the ambulance? They'll take you to the emergency room. They'll get you something for the gallbladder and you'll be good to go. He's like, I'm not getting in. No, his swear words. Ambulance. And I said, okay, how about I take you? I'll take you. I said, I know the doctor's there. We'll get you right in. So he goes in the house to grab his wallet and his insurance company. As he is, I'm calling the doctor that I work with in cardiology. And I said, listen, my uncle's having an MI. I said, it is like unstable angina. And I said, he will not let me call the ambulance, but I'm bringing him, have him ready. So the doctor called the heart team, had him ready. He gets in there. He was 90+% blocked in his left main coronary artery. 45 minutes later, he was getting open heart surgery. 45 minutes. As soon as he got there, they started him on heparin. They started him on a nitro drip, heparin. And they said, call whatever family member you need to, but you're not going to make it for 3 more hours. You need open heart right now. So I tell you that story because he was unstable angina, right? But that didn't stop him from getting open heart in 30 to 40 minutes. Okay. And then of course he didn't talk to me for like 3 weeks because he's like, you lied to me. And I said, yeah, but you would have had a heart attack and I would have been doing CPR on you in the front yard while you're cutting the grass. So you're welcome. You could be mad at me, but you're welcome, So I think his wife made it there, but his kids didn't even make it to the hospital in time to see him. And I said, you have to go to surgery right now. They didn't care if he ate, they didn't care if he drank, they didn't care. They said, if not, he's going to die. They didn't even feel like he was stable enough to keep him on heparin and nitroglycerin until he was able to have surgery. So I just share that story with you because even though it's unstable angina and that vessel was not 100% occluded, still significant enough. So going back to your question, Kara, unstable angina and MI are both bad and they both require immediate intervention. Okay, so let's go back to diagnosing, right? So how do we diagnose an MI? We already told you, you had to have your biomarkers and you had to have your EKG. So do you need to know the EKG and the parts? Yes, you do. Okay, so if we look here, so this is lead 1, 2, and 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So if I picked this chart up and I put it on top of the heart, here's the right side of the heart, here's the left side of the heart, and look at how they go together. It actually tells you where the heart attack is happening. So if I have a lead change or an ST elevation in lead 1, I'm going to confirm that in AVL. If these two to go together and there's an ST elevation here, this is actually right lateral, not right anterior. I'm sorry. When you guys get this, make sure you mark this out, and this is right lateral. So lead 1 and AVL go together. So if I see an ST elevation in AVL and 1, then I'm going to say, oh my gosh, this is the right side of the heart, and this is the area that's being affected. If I have a lead change in 2, 3, and AVF, guess where that is? That's the inferior part of the heart. So think of your heart. You know, Mrs. Phillips probably brought her beautiful little heart up to class yesterday. And if you think about it, your heart kind of sits on the right side, right? This left ventricle has all this space to pump, right? So if we look at this heart, right, and we say, okay, 2, 3, and AVF are inferior, yeah, they're right down here. That's where the EKGs pick up. It's the inferior, the bottom part of the heart, right? So if you think about it, you take your EKG and you put it in front of the cardiac heart, septal, right? I think of septum down the middle of your nose, right? The septum is down the middle. Same thing. V1 and V2, look at this. If I pick this up and put it over here, V1, V2, septal. V3 and V4, this is left anterior, right? This is the left side of the heart, left anterior. That's your moneymaker, right? Your widowmaker, your left anterior coronary. And then you have V5 and V6, which is lateral. And that's like your left circumflex, okay? So if you have something that's happening in V3, you're going to check lead V4 because we know these go together. And this is the left anterior portion of the heart. And if you see an ST elevation here, you know that if you don't get this fixed right away, your patient's going to die because this is the blood that feeds this left ventricle. So if you have something in V3, V4, V5, V6, that blows out this whole left ventricle. The patient cannot live without a left ventricle. Okay. So do you need to know this? Yes. Yes. You need to know that V3 goes with V4. You need to know that V5 goes with V6. You need to know that V5 and V6 are left lateral. You can see the left side of the heart. You need to know that this is left anterior. This is septal. V1 and V2 is septal. That this is right lateral. So V1, or I'm sorry, 1 and AVL is right lateral, and then 2, 3, and AVF are inferior. Okay, and that tells us what part of the heart is being affected. So the EKG is very important. It's one of the first tests that we do when the patient comes into the emergency room and we're trying to work them up for their chest pain. Okay. And then, of course, the second diagnostic are your MB, your CKMB, and your troponin, right? So at 4 hours, this is when you will see them spike. This is their peak hours, and then this is how long the duration. Okay. Here's your levels. You need to know that. Okay. You need to know that. Okay. So then she talks about an area that's called the zones of damage. Okay. The zones of damage. And I have to think about this backwards because you're like, oh my gosh, the zone of damage. This is like 12. This little picture here is like 12 slides of her PowerPoint. Okay. But this is how I think about it. So I'm hoping it'll help you guys. The zones of damage. So we work backwards. So if our patient's having unstable angina or an ST elevated MI, we're going to see that EKG change, right? Well, where are we seeing it? Where's our zone of damage? Well, ischemia means that it's pretty reversible. It means that we're not getting enough, the vessel's not 100% occluded necessarily yet, but that we have a little bit of damage, but it's reversible. So we're a little bit hypoxia. So we have a little bit of ischemia to the tissue. So we're going to see a T wave change. We work backwards. So ischemia, it's the least severe. we're going to see a T wave change, and this is reversible. If we see this T wave change on the patient and we say, oh my gosh, we think that they're having an ST elevated MI or unstable angina, we do something right away. This could be completely reversible. The next, if we don't catch it here, now we start to see an ST segment change, right? So now I start to see this ST elevation, right? And if you guys remember from the case study, I know that you guys didn't get to go over it. Some of us talked about it on clinical this past week, but you guys didn't get to go over it, so maybe Monday. But you see this ST segment change, right? Up or down. And if you guys saw that on the EKG that you guys did, you saw this elevation above your baseline. So that's an injury. So part of that could be reversible, but part of that, we've injured that cardiac tissue. So that means that there's going to be a permanent injury there. Okay. And if we don't catch it at ischemia, if we don't catch it at injury, or maybe the patient stays home, right? Maybe they're a diabetic or a female, and sometimes they don't have those classic symptoms. So they think, oh, it's just pain because I was lifting around my bra strap, or it's blah, blah, blah. You know, they're diabetic and they don't feel the pain. Then we say, okay, now they stayed home. Now it's permanent. We have a full-blown infarction and you have a Q wave, remember? And this is that like depression below your isoelectric line. And that's the worst, right? So now we have this and it's permanent. We'll always have that Q wave because we have permanent damage to that part of the cardiac tissue. So when you think about your zones of damage, ischemia, T wave, it's going to come on first. It's completely reversible. If we catch it there, we're able to save a lot of that cardiac tissue. If we don't save it there, it goes back even further. Now we see an ST segment change. So we're going to have an injury, partially reversible. And if we don't fix it, then it's going to be permanent. We have a full-blown infarction. We have a Q wave. How we doing?
Good. Just your explanation right now has helped me understand this a million times better.
Good, good. Well, so I don't love cardiac. Cardiac is not my GM, but this is how I think about it. This is how it helps me remember it, because I'm not in love with cardiac. Even though I did it for 5 years, it's not my jam. So if I can help you remember how it helps me remember things, then hopefully good.
Okay. So can you go back down? I was trying to move my computer. Like I was going to scroll.
Yes. Okay. Dawn.
Okay.
You're scrolling perfectly. Where would you like
yeah. Great. So the Q wave, you said that is a full-blown infarction.
Yes. It's irreversible.
So that's the only time you will have that.
Yes. Yep.
Mm-hmm. And then I sent you a message. I know it's off the wall, but you said when your uncle went in, they gave him heparin, which I know will prevent blood clots, but I'm guessing the benefits outweigh the risk when you're going to surgery, because wouldn't that?
So the half-life of heparin is so short. Immediately when you shut off that drip, they usually shut it off like 30 minutes before surgery. So they could reverse it if they need to, but yeah, so they put them on a heparin drip because it's very quickly reversible.
Okay, thank you.
Sure. Yep, the half-life is super short on heparin.
For the non-STEMI, it won't have any ST change, like
correct
up or down. Okay.
Correct. So this is why if a patient comes into the emergency room, and you ladies that work ER can tell you that somebody comes in with chest pain, they do an EKG. They don't rely solely on the EKG. They'll say, okay, they're not having a STEMI. Okay, we don't see a full-blown MI here, but we don't let them go until we get those biomarkers back. Because look, this is the perfect example. You can have a non-ST elevated MI, but you could have positive biomarkers and the patient is still having a heart attack. Yep. Does that answer your question, Leah?
So with the biomarkers, is it the CKMB and the troponin?
Correct.
Okay.
Yep.
I have a question.
Yeah.
So we learned last semester about like unstable angina or whatever.
Mm-hmm.
I thought that was the one that was I'm sorry, not unstable, stable.
Stable. Yeah.
Like I thought that unstable was like all the time, like your chest just like always hurt.
No. So stable angina, those patients will have chest pain. They carry nitro with them all the time. And the nitro relieves the chest pain, but that's usually they have a coronary complication where the angina is stable, nitro relieves it. And as long as the chest pain goes away, they don't necessarily have to go to the emergency room. It's if they would take the nitro and the nitro wouldn't relieve the chest pain that they would have to go, because that means that coronary complication has advanced, but it's considered stable.
But so then like in the signs and symptoms, when you said unstable angina is 2 to 5 minutes, I thought to be unstable, it had to be like longer.
It doesn't, no, it doesn't have to be. It usually lasts 2 to 5 minutes because most of the patients sit down and it's relieved by rest. Nobody starts having terrible chest pain, these chest pain pressure, and it's like, oh my God, this chest pain, I'm going to start running a mile. So we say 2 to 5 minutes because majority of the patients, when they start to feel that pain, what do they immediately do? Sit down or stop the activity. So that's how we know it quantifies it, is that 2 to 5 minutes. The other thing I've seen in the literature, but this would be like if my uncle would keep cutting the grass, actually he would have had a full blown MI if he wouldn't have stopped and taken the rest. Sometimes we'll say up to like 15 minutes. You might see that in the literature a little bit, but historically we say like on average, it's about 2 to 5.
Okay, and you can,
Sorry.
it's okay,
Last
you
semester
can
they-
move it.
Go ahead, Carrie, you finish and then I'll go to the next person, just so we're not talking over each other. Go ahead.
I was just gonna say that is relieved by nitro, even though it's unstable.
Correct.
Okay, thanks.
Yeah, because the vessel is not completely occluded. So if the vessel is not completely occluded, right, and I have blood that's flowing through a little bit, if I give nitro, it opens up. Yeah, absolutely. Yeah.
Last semester, we did learn that unstable angina was not relieved by rest or nitro at all. Like that's what
Okay.
Deb taught us.
Okay. Look at your PowerPoints from this semester. Do you guys see a section on there about unstable angina and how it's usually relieved by rest? I'll pull it up and double check it.
Okay, thank you.
I guess we're just trying to get the difference between stable and unstable.
Yeah. So
Like, They're a
So-
defining characteristic between the two.
So, I mean, so you're not going to have any questions on this test about stable, but just for knowledge purpose as a nurse, stable angina are usually patients that like have been like stable angina. Usually these patients have been worked up and they've already had a heart cath. They've had diagnostic testing that says, well, yeah, you have chest pain when you do this activity, but they don't necessarily like there's somebody that gets chest pain, but it's not necessarily something that they're going to go into a full-blown MI for every single time they get that chest pain. So it's usually considered stable. We give them the nitro. These patients that come in with unstable angina, this is like a new problem for them. So this is like a new problem, new chest pain, and we have to do something about it. It's not stable because if we don't do something about it, it's going to completely occlude the vessel and turn into a full-blown MI.
With stable and unstable, it's on slide 14 from
Mhm.
our PowerPoint that we just went over with Mrs. Yeah.
Phillips. Okay.
Yeah.
So what I have here, is it different than what she has on the slide?
No, actually it says stable angina is predictable, usually exercise induced, control achieved within 5 minutes of rest or nitro. And it's my usual chest pain. So like, okay,
So these are the patients that we've worked up. So if that makes more sense in your guys' mind, like these are the patients that presented with chest pain at some point. We know that they're going to get chest pain if they engage in too much activity. If they rest, they take the nitro, their pain goes away. So unstable angina, if you have somebody that has unstable angina, they rest. As soon as they get back up, like my uncle, and start doing activity again, their chest pain comes back because it's unstable. In a stable patient, they rest or they take their nitro, they rest for a few minutes, and then after a little while, they get up and do something else. That pain doesn't come back immediately. It's fine until they start to engage in some vigorous exercise again in a couple days or something like that. Where does that make sense to you guys? Where the unstable is like, oh no, like this is unstable enough, even though it's relieved by rest and by as soon as you start to do something else or that stress is brought back on, whether it be emotional stress or physical stress, that patient is in the same predicament that they're going to go into a full-blown MI.
yeah, for unstable, it's a change.
Yes.
And it's more
It's
intense and
Yep.
it's like from when they're awake till they're asleep and they need more nitrates for relief and needs immediate attention, call 911.
Yes.
So
So if you had, like I said a little bit ago, if you had a stable patient and their chest pain
So
got
Jill,
new, different, or
I'm
worse,
sorry.
then if their chest pain got new, different, or worse, then they would seek medical attention because now they've gone from stable angina to unstable.
So if it's new to them, like the unstable angina, or stable, how do you educate your patients as to when to go to the ER versus if it's not relieved, or do they go,
So
you know what I
if the
mean, to
patient, if the
differentiate?
patient has stable angina, they're going to know they have stable angina because at some point they presented to the emergency room or the doctor's office with chest pain. And then they had a full workup that said, oh, you don't need to have open heart surgery. Your vessel's not near blockage, but when you engage in activity, you start to have this pain. So we consider the situation stable. If you rest and take nitro, the pain will go away. It's very controlled. You know what brings on the pain. But if it's different than what you normally experience, then we want you to come to the emergency room. If you're the first person, if this is the first time you've had chest pain and we work you up, we're going to quantify you as either stable or unstable. So if you're stable, we're going to say, okay, this is what you need to do. This is when you need to come in. This is when you take nitro. We're going to give you other medications like beta blockers and ACE inhibitors and all those other things to manage your stable angina. If this is the first time you're having chest pain and you come in and you see you're 90% blocked, you're unstable angina. You're not going home and we're going to, well, if this gets worse, come back. Because right now it's stable. No, unstable angina, those patients will never go home and be considered stable. They will require immediate intervention, either admitting to the hospital, open heart surgery, coronary heart cath, TPA, something like that.
So if it's new to you though, like, and they come in and there's no evidence of their biomarkers changing, there's no ST elevations, but they are experiencing chest pain, what they believe to be chest pain and may or may not be heart related. How do they determine whether they keep that person or not, or whether they just send them home and think they're quote unquote anxious or another issue?
That goes up to the provider. So they would look at the risk factors, like, are they a smoker? Are they overweight? Do they have a family history? Do they have hyperlipidemia? Because if their biomarkers are negative and they have no ST elevation, but they've smoked for 50 years, they're overweight, they have a family history, they had a brother that died of a heart attack at their 50s and this person's 60, and they have a hyperlipidemia, you better believe we're still going to work that patient up. We're still going to take them to the heart cath. We're still going to do diagnostics to look why, maybe a coronary CTA or angiography to see if there's any blockages, if the patient has stable kidneys. So that really goes that really goes up to the provider, and there's no like hard stopper on that. It goes to each patient's risk
I just
factors
wondered how they determine who goes home and who's not. So is valvular heart disease any type of predictor as well, if they have some level?
You can have
valvular
somebody that has valvular heart disease and their coronary arteries are completely fine.
Oh, okay.
So they sometimes go together, but they don't necessarily. So we just look at you have to step back and look at the whole picture. What are their risk factors? Do they drink alcohol? Do they have a poor diet? Are they overweight? Or do they have a family history? Have they been hypertensive? Right? You guys know hypertension for years and years will damage the blood vessels. It causes atherosclerosis. If they have calcium buildup because they have a hyperlipidemia, and even if they don't have these markers and they're coming in with chest pain, we always assume it's cardiac until proven otherwise. So once we come in with those risk factors, they're going to go ahead and look at that patient and do a coronary CTA or get them to the heart cath and find out. If it's negative, then the heart cath is negative and they say, oh gosh, there's no blockages. Maybe it was just extra stress or something like that. They might say it's a stable angina. Does nitro work? And then they go there and say, okay, maybe this is stable and we can give this, and this to help this patient. Is that helping you guys a little bit?
Yeah, it helps a lot. I just wondered when they come in through the emergency room, how they determine, okay, this person's okay to either, go home, or this one needs further workup.
We never determine that without doing further workup.
Okay.
And if we ever make that assumption, then that's a risk. That's a huge risk we're taking.
Right. Okay.
If you ever you got to always look at all the risk factors and what the patient presents with.
Especially like what I would guess, like in females, because they present so differently than males in some cases, and then it might not even look like, oh, they're just.
Well, for years they were saying that women were coming in because they had non-traditional chest pain. They were like, oh, I have pain in my elbow. Like, remember the case study, right? She was like, oh my gosh, I have pain in my elbow, or numbness, or they would feel anxious or worried, or this feeling of impending doom. And everyone's like, well, it's anxiety. They were sending women home with medication for anxiety when here they were actually and they would have pain across their bra strap, and they would be like, oh, they're lifting kids, or they're lifting their grandkids, or they're, and they looked at all these other things. And then the research showed that women were actually having heart attacks and we weren't picking up on it. So now we're so much smarter in saying that everybody that comes in with any of these symptoms needs worked up in some way, depending on what their risk factors are and what their diagnostics show when they first come in the door.
Okay, that makes sense.
I have a
Thanks.
couple questions about the ST segment.
Yes.
Like under your zones of damage, and then you have injury, ST change. So that could be ST elevation or ST segment depression.
Correct.
Okay. I know what they look like, but what does the ST depression mean? It's just exactly the same. It's just partly reversible showing.
Yeah. So when we think about conduction, and I didn't go over this with you yet, because you guys aren't going to learn, you'll learn conduction probably on Monday. When you think about conduction, okay, so when you think about the heart, okay, the P wave is atrial conduction. So it's like P QRST, P QRST, P QRST, P QRST. So when we look at this EKG strip that I have up there on the monitor, so the P wave, okay, is your atrial conduction. When your atria relaxes, your ventricles contracting, right? So we're like this. So they're almost opposite. And then we have a pause. So P QRST, P QRST. So when we have ST contraction, or we have ventricular depolarization, right? Ventricular depolarization, that means that is contracting, okay? So that's your QRS, right? So that big QRS, like boom, 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 that is ventricular depolarization. And when it starts to relax, that becomes your S and your T wave. It's like boom, boom, okay? Well, why do we see a T wave inversion? Because at first we have a problem with the ventricle completely relaxing. Now they have this hard contraction and problem with relaxing. And if we don't fix it on the T wave with problem with relaxing, now we're going to start to see that change at the end of depolarization. So you might see it depressed because it's not able to relax as well, or you might see that overconduction where we have this ST segment elevation because we're not able to relax the muscle very well. So you'll start to see the changes on depolarization first.
Okay. And then I'm looking at the slide for the acute cardiovascular. It says classification of acute coronary syndrome. And STEMI, non-ST elevation, myocardial infarction, can have ST depression.
Okay. Like a yes, it can have an ST. So when we look here, up here, we're saying there's no, so here we have an ST change. Here it says no, it says a negative ST change. When we're looking at this, we're looking at the ST elevation.
Okay. So it has nothing to do with ST depression, even though ST depression is the
It's not that it doesn't. It's just not that easy to say yes or no, one or the other. It's not 100% yes this way or this way.
Okay.
So let's just make this very clear. If your patient comes in, if I can be like silly for a second, if your patient comes in and they say, oh, we have an ST depression and positive biomarkers, screw it. It's only ST depression. No, we're not going to say that. We've got positive biomarkers and ST depression. It's a non-ST elevated MI, right? Because that's what that stands for, non-ST elevated. So it's not elevated, but it's depressed, right? Are we still going to treat that patient? Yeah. What are we going to do? Everything that we would do for an ST elevated MI, everything that we would do for a non-ST elevated MI. So there's no like cookie cutter, like absolutely 100% we do this. Absolutely 100% we do this. If any of these patients come into the emergency room with unstable angina, non-ST elevated MI or ST elevated MI, you better believe we're giving them oxygen, we're giving them morphine, we're giving them nitro if they're hemodynamically stable. If it's not an inferior wall MI, we might be trying a beta blocker and we're getting their ass to the cath lab. So no one's going to sit there and debate at the bedside that it's not an ST elevated MI, but because that's all this means, right? Non-ST elevated. So you can have an ST depression. So if we come down here and we look at this, if I see that I have a T wave change and I've got some kind of ST change, you better know that there's an injury in that cardiac tissue. No one's going to stand at the debate. And I know you're like, just because you're like, if I get a test question about this, I've never seen it be that tricky. I would never, because you're not the cardiologist that's making the call. You as the nurse are responsible to make sure that you know the lab values, so that if you see an abnormal lab value, you know that it's related to this cardiac perfusion issue. If you see an ST segment change, an ST segment depression, a T wave elevation or inversion or a Q wave, we know that that is a major issue with the heart, right? And then you're going to look at this EKG because you need to make sure that you confirm that it's occurring in the right place. So if you see a ST segment change, increase or decrease in V3, you better know that you're going to look at V4 as the nurse, because you're calling the provider, say, hey, I just got an EKG. I got an ST segment elevation in V3 and V4. I'm worried about a left main coronary artery. And you're like, let's go, cath lab. Here we go. Do the workup for the cath lab. Does that make sense a little bit? Does that help, Leah?
Yeah, because we're treating them the same because they're having
you're really like, I'm helping you identify the difference here. But at the end of the day, if you have somebody that has positive biomarkers or a positive EKG, you better believe our goal is to get their butt to the cath lab. Our goal is to get them to the cath lab. We've got to provide some kind of intervention. And if they can't go to the cath lab, then what else are we doing to save their life? Because if not, they're going to have a massive MI likely. Does that help some? Does that help like
Yes.
make it maybe not so linear exactly?
So Joe, would we ever have like a change in like V3 but not V4? Or like, would that just be like, oh, it's not accurate? Or
Yeah, we would be like, is there some kind of artifact? And then again, you're going to go back to your patient picture. Why did you do the EKG? Were you doing it because you're just ruling out like they're going to have a test and we just want to make sure that the heart looks okay? You know, EKG is one of those pre-admission testing things that we do for some patients. Or are we doing it because the patient's here with terrible chest pain? Then we're saying, okay, well, that's weird that we have a lead change in V3 and it's not signified in V4. Let's go back and look at those biomarkers and see what else is going on with the patient. But we got to make sure that it's not artifact, which is why we confirm it in 2 leads.
okay, great, thanks.
How are we doing? Okay.
Yep.
Perfect.
All right, we're going to move on. I never had somebody ask me so many questions about that part of the presentation. So you guys are thinking, I like it. Okay. No, you're okay. Don't ever be sorry. That's why we do this. Okay. So treatments and, you know, security is not my thing. So I'm like, wait, so I have to think about it. Okay. So treatments. All right. O2, right? Always pick that answer. We're always giving oxygen, right? Nitroglycerin. Okay. Before you give nitroglycerin, what do you have to ask? Did you take Viagra? Did you take another vasodilator? Right? Because remember Viagra, we just studied it. And this is why we build on top of what you guys are already learning. Viagra is used for an elevated pulmonary vascular resistance, right? So we do that to decrease the pulmonary vascular pressure. So people use it for erectile dysfunction, but they might be using it for pulmonary arterial hypertension. So did they take a Viagra? Did you guys ever see that movie? It's Complicated with it's not Meryl Streep, Diane Keaton and Jack Nicholson. Anybody ever see that movie?
I think so.
Yeah.
Is that called It's Complicated? No.
No, you're thinking of a different one with
Yeah. I'm thinking of Meryl Streep. Okay,
Yeah.
but what's the movie that I'm thinking about? Where like he's dating her daughter and then he goes up to their lake house and he ends up falling in love with her. Do you guys know what movie I'm talking about or no?
I know
I
what you're
do, but I
talking
don't
about and I'm
know the
gonna
name of
find
it.
it.
Okay, all right, Taylor, come back. So if you guys remember that movie, there's a part where like he's, starts having chest pain, right? And they're like, and he's dating this younger girl, right? And like he's dating like this, like a girl half his age. And he's like, I'm having this chest pain. They call 911. They take him to the emergency room. And Keanu Reeves, I think, is the doctor. And he's like, did you take any Viagra? And he's like, and he looks at the girl that he was like, just making out with. And he's like, no. And he's like, because the medication I'm about to give you, if you've taken Viagra, it can kill you. And he literally like rips the IV out of his arm.
Is it Something's Gotta Give?
Something's got to give. That's it. Yes. Thank you guys. Thank you. So I always think of that. And that's what I think of when I think of this. I think like you think of that movie, like you got to ask the patients, did they take Viagra or some other vasodilator before we give nitroglycerin? Can we give morphine? So think of Mona, right? Morphine. So we're going to give aspirin. They probably should have had it already on the way to the hospital, but we have them chew an aspirin. Why is that important? It's an antiplatelet therapy, right? So it prevents the platelets from sticking together. Perfect. If you have a vessel that's occluded with coronary sludge and platelets, what happens? If the body senses that there's a problem in that area, what does it do? It sends platelets there and white blood cells because it wants to make sure that it actually fixes that problem. So we don't want those platelets. We're not bleeding. Those platelets are harmful. So we give platelet give aspirin because that prevents platelet aggregation. So they're not going to stick together. We give oxygen, we can give morphine. Morphine actually helps the patients with their chest pain and relaxes, it decreases the myocardial oxygen demand and supply needed. And then we can give beta blockers, right? So you hear me talk about calcium channel blockers and beta blockers all the time. Beta blockers are one of the #1 drugs we give as a nurse. You guys have probably all given some kind of beta blocker like metoprolol or labetalol, right? So we can give a beta blocker. Why do beta blockers work? Well, they block beta 1. So if the heart's like this, bing, 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 right? It's beating fast because we're probably short of breath and hypoxic and our cardiac output's not good. So it's beating faster. Well, now you're making the heart work harder. Well, that's not good because I can't get enough blood to that coronary tissue as it is. So we give a beta blocker, slow it down. It decreases the workload of the heart. It decreases the myocardial oxygen demand. It stops how much oxygen the heart needs. Good, because I can't get a lot of oxygen there. So I don't need to try to get it more. But you can't give that if they're in, you can give it, but they can't have heart failure or an inferior wall MI. So remember that lead 2, 3 at the bottom down here, 2, 3 and AVF. If it's an inferior wall MI, we're not going to give a beta blocker. Okay. It doesn't help them as much as we'd like. Okay. Treatment, we got to get an IV in, right? We got to get blood work. We got to get our EKG. That's your standard of care. Do vitals, get an EKG, get an IV in, get our blood work and start giving these drugs. Start as you're doing blood pressure, chew an aspirin. Let's go. If they have GERD and it's not an MI, no problem. Is the aspirin going to kill them? Nope. If it's a gallbladder problem, is the aspirin going to kill them? Nope. But if we don't give the aspirin and it's a heart problem, could they die? Yes. Right? Okay. So then what's our next goal? So they come in, you're working in the emergency room and you're like, okay, we got oxygen on, we got cardiac monitoring, we sent our blood work, we got the EKG, it's an ST elevated MI. We got to get into the cath lab as soon as possible, right? We've got to get into the cath lab as soon as possible. So ASAP, we're going to give Brilinta 180 before. And you guys were just asking me about heparin, right? So heparin's a blood thinner, but Brilinta is an antiplatelet therapy and it works really, really well. So on the way to the cath lab, we're giving them Brilinta because as we're going into that coronary arteries and we're checking those out, we don't want platelets in there clotting things around, right? We don't want platelet aggregation. So we use Brilinta. And then let's talk about the types of heart caths. So if your patient comes in with chest pain, they're actually going to have a left-sided heart cath. So that means, and you think about how do you get to the left side? Well, they're going to go into the left femoral artery or the radial artery, and the catheter is going to go until they hit the aorta. And then it's going to go up the aorta. Remember, there's those 3 branches off the top of the aorta. Like if you guys think of that heart picture that you had, right? One of them goes up to the brain and the spinal cord. The other one goes to the upper extremities and perfuses the blood around the chest wall. But one of these blood vessels actually brings the blood back to the coronary tissue. So all this blood, so that catheter goes up through that blood vessel. And now it's starting to look at the blood vessels in the cord that feed the heart, the blood. Okay. So if we're doing a left-sided heart cath, this is for chest pain. We're looking at the coronary arteries. We're looking at cardiac output, right? Because if we're going into the aorta, can I measure the cardiac output coming out of that left ventricle? You better believe it. We're looking to see the stroke volume, the cardiac output. What's the flow of the blood out of that ventricle? We're actually able to go into that ventricle and we're able to look at those valves. Well, what valves are on the left side of the heart? Well, your mitral valve, your aortic valve. So we're looking for a mitral valve and aortic valve stenosis, regurgitation. So we're looking at the left side of the heart. If somebody's coming in for chest pain, they're going to have a left-sided heart cath. But if we're doing a heart cath because we're worried about pulmonary hypertension or we're worried about heart failure on the right side, they're actually going to go into the right femoral vein and you're going to go up the inferior vena cava, superior vena cava, and they're going to go into the right side of the heart, just like we would do if we were putting in a swan, the right ventricle, and now they can go in to look at the pulmonary artery. So if we're doing a right-sided heart cath, we're going to go in through the vein because the vein is what feeds that right side of the heart, right? It brings the blood back. So we're looking at right-sided heart failure. We're looking at the pulmonary artery because we can go the right atria, right ventricle, pulmonary artery. We're going to look at the valves on the right side, which would be your pulmonic, is the blood that leaves that right ventricle and takes it to the lungs, or the tricuspid, which is the valve that separates the atria and the ventricle. Okay. So if we have complications of these, let's say you have a left-sided heart cath, well, what are you worried about? Well, of course they can have an MI. If I'm in there messing around with those coronary vessels and they're already having chest pain, could they have an MI? Yes. Could they have a stroke? Of course. I'm in the aorta, in that left ventricle. that blood that pumps out of the left ventricle, if I inhibit the blood flow or knock something loose, like maybe there's calcium buildup on that aortic valve or the mitral valve, and I knock something loose, remember those 3 blood vessels off the aorta, that blood is going to come out and it can go and cause an MI. That piece of calcium that broke off can go into the coronary vessels and come back to the heart, cause an MI. It can cause a stroke, right? This one's going to come up to the spinal cord and the brain, and it can actually cause the patients to have a stroke. We're messing around in these different chambers of the heart. So of course they can have dysrhythmia, and of course we have to worry about bleeding. If we do a right side, this is we're going in the vein, almost like your swan, going into the right side of the heart, right ventricle, pulmonary artery, we can throw a PE. So just like on the left side, you can knock something loose, which would send the blood to cause you to have a stroke. If you're on the right side and you knock calcium loose on that tricuspid valve or that pulmonic valve, it's going to take that clot or that piece of calcium and throw it right to the lungs, right? Because right after that right ventricle, the blood goes in the pulmonary artery into the lungs. Okay. And then the patient can vagal. We can lose the heart rate because of our stimulus there. Okay. Are we good? Right-sided versus left-sided. Can you guys visualize that?
Just real quick, you said the left-sided one is if they have chest pain. What is the right one for?
Everything else over here. Heart failure,
Oh, those are
pulmonary
the-
artery. Yeah, tricuspid. We're looking at the tricuspid pulmonic valve, looking at the pulmonary artery, and right-sided heart failure. Left side, if they come in for chest pain, they're going to have a left-sided heart cath. So if they come into the emergency room, they're having chest pain, they're not taking them to a right-sided heart cath because we can't get to the coronary vessels. We have to do a left-sided heart cath to get to the coronary vessels, but they're looking at the coronary arteries. They're looking at the amount of blood that's being pumped out of the heart. They're looking at the valves on the left side, which would be the mitral and the aortic, and the blood flow through that left side of the heart. So once we get to the half, great, we're in the cath lab, right? And we're in the left side of the heart, right? So what are we doing while we're in there, right? We're not just going in there to see if there's something there. If we can fix it, you want to fix it while we're in there, of course, right? So we can do a balloon atherectomy. So that's where they take the catheter. So we got the catheter that comes up the aorta, right? Comes up here, it comes up this artery, and it goes back to the heart. And if we have calcium buildup, but it's like maybe 70 or 80% blocked, could we put the catheter in a balloon in there and blow that plaque up? Yeah, what it does is it expands and pushes the plaque against the wall of the artery. Okay, so we can do a balloon, and then we can do an atherectomy, which is where they actually go in and they balloon it open and they remove part of the plaque. After we do that, we can put a stent in, right? So we can put a drug-eluting stent. And if we put a drug-eluting stent in, these patients need dual antiplatelet therapy for 12 months. Okay, big deal. We need to know that as a nurse. Anytime somebody comes in and you see them on dual antiplatelet therapy, so you see them on aspirin and Plavix or aspirin and Brilinta, you in your mind should be saying, and there's something really important that they're on 2 antiplatelet therapies, and we never stop those drugs unless we speak to the cardiologist, right? Because maybe they had a heart cath like 8 months ago. Okay, we can't stop them off. We don't want to take them off of that medication and hold them and keep them NPO for a colonoscopy, and then they have a massive heart attack because they were going for a colonoscopy. Okay, so we can do the balloon angioplasty and push the plaque against the wall. We can do an atherectomy where we remove the plaque out. We can put a stent in, and we can have a drug-eluting stent, which means it releases the medication to keep the wall of the vessel open, and they have to be on dual antiplatelet therapy for 12 months. Or we can have a bare metal stent. These are older and cheaper, and I don't see them used often, but they're still documented in the literature. And they need to be on dual antiplatelet therapy for 1 month, and then they go back to single antiplatelet therapy, and they'll just go back to like Plavix or aspirin. When I used to work in GI, we would have patients that would come in that would be on dual antiplatelet therapy for a colonoscopy or an EGD. I never stopped it. They would be on antiplatelet therapy and have their procedure. If they needed to come off of that medication, we would postpone the colonoscopy. Even if the patient was anemic and we thought they were bleeding, guess what? I can always give them blood. Okay, I can't give them back their heart if they lose it, right? So we were super careful. We would do these procedures on aspirin and Plavix, or on aspirin and Brilinta, because the cardiac perfusion is so much more important. We couldn't stop the medications just for a colonoscopy or an EGD, even if the patient was bleeding. Okay, so that's the rule. They go for a heart cath. We've got to find out what kind of stent was put in, and we've got to make sure we educate our clients on not stopping that therapy. So they come back to their unit. I was hoping we had somebody that went to the heart cath, went to a heart, we're going for a heart cath on Wednesday and we didn't get to recover them, but so recover them. Then we have to assess for chest pain. So if your patient has chest pain anytime after a heart cath or TPA, it's an emergency. Mark that down and put it in your mind, because you will take care of patients that come back from heart cath. They should not have pain. The heart cath does not cause pain. If they have chest pain after we've given TPA or after we've done coronary intervention like a balloon or atherectomy or a stent, that means that that vessel, we assume that that vessel has reoccluded until proven otherwise. That's a 911 emergency. You call, you get them on the doctor on the phone, you get them back to the cath lab. If it's if they had TPA and they start to have chest pain, you call the cardiologist and find out what the next step is. Okay, because it's an emergency. Okay, post-op care, we've got to check the site. Everything you need to know about being a nurse started in 110, right? So what are your 6 Ps? Do we have pain? So if they went into that femoral artery, guess what? That femoral artery supplies all of the blood to that leg. Okay, if that occludes, what's going to happen? Now we have an arterial insufficiency, which means I'm not getting good oxygenated blood to that extremity. So what are the patients going to look like? Pallor, so they're going to have a pale extremity, decrease or no pulse. It's going to be polar, it's going to be cold. They're going to have paralysis and paresthesias, and they're going to have pain, right? So don't forget your 6P assessments. If we went into the femoral site, a lot of times they're on bed rest for 4 to 6 hours, and we have to do frequent vital signs after. So when they come back from a heart cath, I think it's like vitals every 15 minutes times 4, then every 30 minutes times 4, then every hour times 4, and then every 4 hours. Okay, so we're doing vitals consistently. Okay, we want to make sure that these patients are bleeding afterwards. You're checking the site, you're checking your 6Ps. You want to look for any edema, swelling, anything like that. We can give TPA. So let's say your patient's got really bad kidneys and they will not tolerate the dye that's needed for a heart cath, and they can't go for the heart cath. Something is unstable. Then we can consider doing TPA, which is a clot buster. Okay, so if you're going to give TPA, so let's go back to the heart cath. If you're sending your patient to a heart cath, of course you got to make sure they get the Brilinta. You have to make sure that they don't have an allergy to like IVP dye or shellfish, right? Because we're going to give dye during that procedure. You have to look at their renal function, right? Because if their renal function's bad, you give dye, you're going to shut down those kidneys. If we're going to give TPA, so it's a clot buster. It's not a blood thinner. That means it physically goes in, that medication physically goes in and breaks up a clot. Well, is that a smart thing to give somebody that just dropped a baby out of their uterus? Nope, they're going to bleed. How about if they just had surgery or were not major trauma not that long ago? They will bleed, right? If they had major surgery, recent trauma, if they're pregnant, if they recently had a stroke. The other qualifying factors is for cardiac reasons of using TPA, they have to have a blood pressure less than 200/120. If their blood pressure is super high and I give a clot buster and now I have a medication that's breaking up clots with a high pressure, are these patients more likely to have a stroke? You better believe it. So we have to have a controlled blood pressure of less than 200/120. It doesn't mean that we wouldn't give the TPA, but we're just not going to give the TPA until the blood pressure's down. Well, how do we bring down the blood pressure very quickly? Well, you learned these drugs for the last exam, Nipride, okay, and Clevoprex, okay, drops blood pressure very, very fast. So we can give those medications and then talk to our provider about giving the TPA, okay? If we give TPA, how do we recover these patients, right? You better be doing neuro checks. I'm going to take you back to the brain. Anytime I can take you back to the brain, I will. If your patient gets TPA, one of the biggest risk factors is they're going to bleed or they're going to have a stroke. Well, how do you know they're having a stroke? Well, they're going to have first thing you're going to see is a change in level of consciousness, right? And so think of FAST, face, arm, speech, time, right? So do they have a facial drooping? Are they confused? Do they have slurred speech? Do they have difficulty moving one extremity or the other? Okay. The other thing we need to check after we give TPA is our vital signs. If our blood pressure was 220/120 before we gave the medication and we brought the blood pressure down, we still got to check that blood pressure after because we want to make sure it doesn't go up that high again. What are our clotting factors, right? So PTINR, PTT, and we've got to look for signs and symptoms of bleeding, right? So how do you know your patient's bleeding? Someone tell me how you know your patient's bleeding.
Tachycardic.
They're tachycardic. What else?
Their blood pressure is
Hypotension.
dropping.
They're hypotensive, right? So you don't even have to see frank blood to know that if you gave TPA and all of a sudden your patient becomes hypotensive and tachycardic, something gave way somewhere and we need to figure it out quickly, right? And then they're going to be tachypnic, and then we might start to see a gas exchange problem. So they might be hypoxic. Okay. So we got to think about that, right? So recovery is so important. Teaching after a heart cath or after TPA, very, very, very important. So let's talk about our discharge instructions, right? These patients come in for an MI, they come with unstable angina. We saved their life. Good job, guys. You saved their life. You got them to the heart cath. You figured out by the EKG and the biomarkers where the heart was infarcting. You gave them the Mona. You gave them aspirin. You got them to the cath lab. They got a drug-eluting stent. Now we're sending them home. Okay. So discharge instructions, they have to follow up with their provider. They have to manage their blood pressure and their weight. They have to be able to control their stress and their diabetes. Okay, well, how are we going to do that? Well, we've got to watch our diet, got to watch our cholesterol, stop smoking, no illicit street drugs. We've got to control our sodium. And they have to start exercise. And this is why we have cardiac rehab in our building, right? All those patients either had a stent or maybe have some kind of heart failure or had an open heart surgery or some kind of cardiac procedure. And now we have them in a cardiac controlled training program to regain the strength of their heart. And then the exercise helps with weight control. So dual antiplatelet therapy, do they need to be on it? Yes, anybody that has a heart cath needs to be on dual antiplatelet therapy, depending on what heart cath they had or what stent, not heart cath. Let me say that again. Any patient that had a heart cath, that had a coronary stent placed, needs to leave the hospital on dual antiplatelet therapy. How long they're on that depends on the kind of stent they received. So was it, do they have to be on it at least a year or just 1 month? Okay, they got to be on a beta blocker. Why do beta blockers work? Well, they decrease myocardial oxygen demand. They make the heart work smarter, not harder. Okay, ACE inhibitors or ARBs, why do they work? Well, they block angiotensin 1 from converting to angiotensin 2, and it dilates that vessel, reduces afterload. So now this heart that might be sick doesn't have a high afterload to pump against. Okay, remember ACE inhibitors block from angiotensin 1 to angiotensin 2. ARBs block after angiotensin 2 before it converts to aldosterone. Statins, yeah, if we got cholesterol, we got buildup of plaque in the vessels, we got to give them some statins. And do they need nitrates? They might need nitrates until we know for sure that they're stable. So sometimes we send them home on nitroglycerin so that they would start developing chest pain within a few weeks after having their procedure. You know that that's an emergency. They need to take a nitro, call 911 and get back to the hospital. Okay. That page and that little section there is your PowerPoint from the last, I don't know, whenever Mrs. Phillips started presenting. That's acute coronary syndrome. Questions? I'm going to go ahead and stop recording so this isn't too long.